Thank you all for coming today for our October Preventive Medicine Grand Rounds. First of all, I'd like to thank Piper for co-sponsoring our Grand Rounds and our lunch and for assisting us with bringing in our speaker today. Just a couple quick announcements. Please sign in. There's a couple sign-in sheets at the end of the rows here. Please just make sure you sign in. Either you can pass them around or sign as you leave. And just a quick announcement about our next Grand Rounds will be next month, November 4th. It's actually going to be in Ed 2 South. So usually we're over here, but we couldn't get a room there, in room 2305. And our speaker is Dr. Christina Nelson, who's a medical epidemiologist at the Division of Vector-Borne Diseases at the CDC in Fort Collins. And she's actually going to be speaking about encephalitis surveillance in Peru and her experiences doing an international clinical research fellowship. So it should be a great talk. So I invite you all to come to that. So now it's my pleasure to introduce our speaker today, Larry Cohen. Larry is the founder and executive director of the Prevention Institute and has been an advocate for public health, social justice, and prevention since 1972. He received his master's in social work from SUNY Stony Brook, and he previously served as the founding director of the Contra Costa County Prevention Program, where he worked to build coalitions which helped pass the first multi-city smoking ban, as well as other prevention-focused efforts. He founded the Prevention Institute in 1997 as a national nonprofit center which is dedicated to improving community health and well-being by building momentum for effective primary prevention. And a major focus of the Institute has been reducing health inequalities. He has authored and co-authored several publications, textbooks, and tools, and has received numerous awards. We're happy to have Larry here with us today to share his experience and thoughts. So welcome.
Thank you.
Thank you.
Hi, everyone. I'm really happy to be here. I think my talk is the exact opposite of encephalitis epidemiology in Peru, because I want to talk about strategy and I want to talk about the notion of, in the first place, what could be done so that less people get sick or injured. Interestingly, many of the things that can be done so that people don't get sick or injured are the same things that keep people who are sick and injured healthier, maintaining their health, rehabilitating better. And it requires not just intervention, but it really requires thoughtful strategy and a reframe of the health system, which is why I'm really excited to be here, because more than me, you're the ones who I think are going to be able to play significant roles in reframing the health system. And I hope an hour from now there'll be a bit more fire and confidence in that role. Recently, I was with a colleague in North Beach in San Francisco having coffee, which is my favorite meeting. And she ran into a friend of hers I didn't know. We chatted a minute. The friend asked me what I did. I explained what Prevention Institute does a little bit, this notion of in the first place. And she started crying. I don't usually see people cry about prevention. And I wasn't quite sure what I'd said, what I touched. And she explained to me that she was a physician, had just come from the emergency department at San Francisco General, had just seen someone who was not doing very well, and discovered in the course of the assessment that he had quite severe diabetes that he knew nothing about. And she dealt with the medication issues, and she encouraged him to take care of himself because she thought that was about as important as the medical issues. And she said he really needed to walk at night after he had a pretty hard job, after his job, and he needed to shop for healthier food. And he nodded, and she said the minute he walked out and closed the door, we both knew we'd been colluding in a lie, and I felt like a hypocrite. Because given where he lived and given the job he had and given what time he came home at night, there was no way that he'd be able to walk around safely. There was no way he could get to anywhere which was selling fruits and vegetables safely. And unless, she said, I not only gave out the medical prescription and gave him advice, which she called a green prescription, about walking and about eating better, but also was engaged in helping others make the community changes that were necessary, the work she was doing was not going to succeed. And that's what I kind of touched off talking with her. And really, in a way, that's a lot of the theme of what I want to share with you today. I wanted to start with this picture. And it's a story, as was mentioned in my introduction. I did the country's first no smoking laws, first multi-city no smoking laws, created a partnership between Cancer Society, Heart Association, Lung Association. We were pretty cautious in our first laws. So, for example, it was no smoking in 40% of a restaurant. And we tried to get this passed in all the restaurants across the county, because you don't want one city where there's smoking laws and another where there's not. And so I would ask you, if we took the smokers, and I know there are a lot less now as a result in part of this work, but if we took the smokers and moved them to 60% of the space over here, and the non-smokers and moved them to the 40% of the space over here, would that cure cancer or heart disease or lung disease? You think that would make a difference? Of course not. And yet it did. And the reason it did is what I would call the snowball of momentum building of norms change. Because once we did a 40% law, the next county over did 50%. They said, shouldn't it be equal? And then someone did 60, and then someone talked about 80, and one legislator said 80. Let's just do no smoking at all in restaurants, and then no smoking on beaches, and then no smoking not just in California. And I worked on no smoking on airplanes, by the way. And I can often find a flight attendant on an airplane who remembers when there was smoking. And when I tell them I was involved in that, it's probably the best thing I did in my career, because they immediately moved me to first class. Because it changed their lives, and if they can't move me to first class, at minimum, they bring me wine. So that's, the benefits of this kind of But this, the person who knew about this work said to me, I have to tell you a story, Larry, because I was very excited. I grew up in the Upper Peninsula in Michigan. I was taking my son back there this guy lived in Oregon. For the first time, I was going to show him what what it was like growing up. We drove across the whole country. When we got to Michigan, we found the very diner where my father used to take me every Saturday, and sure enough, we arrived on a Saturday. The menu looked similar, though the prices had gone up quite a bit. And all of a sudden, my son looked funny, and I said, what's going on? And I realized when he pointed to it that he had never seen an ashtray before. Wow. And the reason that's so important is because it shows you, despite the fact that when I did the first no smoking laws in the country, people said to me, that's impossible. It shows you how quickly we can change norms, and how within one generation, what's considered impossible suddenly becomes the standard way of doing things. And every community deals after the fact, and that's critical work to do. But when we talk about prevention, for the most part, people talk about education or brochures. The emphasis on quality is not the same. Just give people information. And so from the very beginning of my career, my goal has been to move beyond brochures, to really the notion that prevention must be systematic. We need quality prevention, just like we need quality treatment. And we need healthcare leaders advocating that prevention really, really matters. And so the key word with prevention is systematic. And the key word with primary is in the first place. What do we do in the first place? And we can't just do it by giving people information and saying, okay, that's enough. That's like doing 1/10 of a medical procedure and saying that's enough. And so we developed this tool, the spectrum prevention, which basically says, in addition to, good morning, or noon, in addition to individual education, in addition to community skills building, we need to have a comprehensive approach. And clearly, the change we've seen in tobacco, for example, through policy. Like in California now, one generation later, there's less than 12% of adults smoke. How did we achieve that? Could we have done that one clinical intervention at a time? Clinical interventions played an important role. Just putting on the medical file of someone a red sticker that said smoker had an impact on people changing their behavior. But the most important things are changing norms and environments. So that's Prevention Institute. And really, although there's an emergency department pretty much in every community, there's only one building like this. And my dream is that there'll be buildings like this everywhere, that we start to really look at things from this direction. So I want to really emphasize the notion that health change requires changing the environment, not just working one individual at a time. So we'll play a game, what's health got to do with it? I like to believe that this owner of this Wendy's was actually well-meaning and didn't understand the destructive impact of a positive attempt. But let me show you the next one. This was a national campaign, the Juvenile Diabetes Research Foundation. Pepsi partnered with KFC. I still insist on calling them Kentucky Fried Chicken, which was their old name. They don't want to be associated with fried or with Kentucky, for that matter. But this was KFC. Buy the big one and we'll donate $1 to the Juvenile Diabetes Research Foundation. Now, I was mad at KFC and I was really mad at Pepsi, but really who I was mad at is JDRF. So I sent them a letter and I said, this is unacceptable. And they wrote me back and they said, Larry, don't you understand? Juvenile diabetes is not like type 2 diabetes. Juvenile diabetes is a medical genetic condition. It has nothing to do with the community environment. Why would be engaged in that? Tells you what we're up against. Just gives you a sense of what we're up against. So how about this one? Is this about health? Is this making people sicker? This ad was in every university newspaper in the United States from General Motors. Why would you be on public transit? It's just all kinds of creepy people on. So what medical conditions are increased by this kind of attitude and this kind of norm? Because I'm saying it relates to health. What are the medical conditions that are more likely if you buy into this approach? What are you going to do differently if you believe that taking public transit and walking there is kind of creepy and you need to have a car? You're going to walk less, you're going to drive more. So what medical conditions are we going to see from people who don't walk? Asthma, more asthma because of the air. What else? Obesity, diabetes, heart disease. All those things are being created. Now, GM doesn't do this anymore. They had another one of a bicyclist, and there was kind of this pretty girl looking out at him, and the same thing. Luckily, there's an affordable alternative. Imagine some guy who bikes. Ugh, how disgusting. Why would anyone want to be with him? Wrong way. This is in Orange County, California, the wealthiest county in California, but there's a very low-income part. So imagine a young kid comes out of their house and sees this sign. So they go to the nearest park, and there's actually no open space until recently in that entire community. So they go to the next neighborhood, to the park, and what do they see? So this is the picture of what's actually happening in the courtyard. Oops, sorry. So you see how these norms play a role in whether people are healthy? What are the diseases you see here? Illnesses and injury. Falls. What else? Infectious diseases. What about diabetes or heart disease? If this is the exercise that people are doing instead of running and playing as kids, So the environment then is a determinant of health. And in fact, studies show that between behavior and the environment, it's 70% of the factors influencing health, and medical conditions are 10 to 15. So how do we focus on both simultaneously? I added this one to cheer you up a little bit. Oh, I'm sorry. Yeah. So this is a park where there is open space. What kind of attitude is being given out by this park when the door is cutely saying, oh yeah, let's go to jail. This is a Florida picture somebody sent me. People send me all these photos now. So obviously, when I say, what's the illness or injury most likely to happen, the first thing people say is alligator bites. But really, what is it? What's going to happen when this is the attitude about walking and biking? It's unreasonable to expect that people will change their behavior easily when so many forces in the social, cultural, and physical environment conspire against such changes. This is the Institute of Medicine. This is a great quote, not only because it's persuasive, but because it's the Institute of Medicine, but it makes it really clear. It's unreasonable to expect that all the people coming in for treatment who need to change their behavior will do so unless part of the treatment is treating the environment which conspires against those changes. So we have to pay attention to both at the same time. And we have to understand there are people working on the environment. And when I did the tobacco laws, it was only physicians standing up and saying, I make my money from treating lung cancer. And yet I'm here to say we could cut it in half. I'm here because I insist on advocating, because I'm a healthcare provider, and this is impossible. This has got to stop. That's what no smoking in restaurants is all about. It was the healthcare voice in partnership with public health, with community, with with patients. It was all, but the voice of healthcare and the voice of patients. Absolutely critical in thinking about that. So here's the point. We understand how the environment affects our health and safety when it's the air or it's the water, right? We need to be equally understanding that the environment affects our behavior by shaping our norms, which shape what's going to happen with us health-wise, and that, too, affects our health and safety. Is that clear? Does that come out of these pictures? Is this making sense so far? Good. I'll get more complicated then. But I want to start by talking about equity. And I want to start where our office is in Oakland, California, world-famous Bay Bridge, goes between San Francisco and glamorous Marin. But the bridge to Oakland, where I work, this is the old one. It just got replaced for $6 billion. I wish they wouldn't knock this. This is the earthquake unsafe one, but I'm kind of convinced the new one may come down and they're going to need this one. And so this is the bridge to Oakland. An African-American child born in the flatlands of Oakland, as compared to a white child born in the hills, which are wealthier, though not super wealthy, there is a 15-year difference in life expectancy based on where they're born. 15 years. For every $12,000 in family income, a year of difference in life expectancy. And so the health inequities we see are not just about individual bad choices, behaviors. They're about things not being fair. And this statistic, unfortunately, done by Tony Iton, our public health director, has been repeated in many major cities around the United States. I don't know for sure, but I would suspect it's been repeated in Denver or Aurora, and you're going to see the same thing. You're just going to see the same kind of experience. And part of it is violence prevention. It's violence and, what needs to be prevented. That's not the only reason, but it's a key piece of it. So what we say is it's not your genetic code, it's your zip code. And the California Endowment, which is kind of the equivalent of the Colorado Health Foundation, has been a big advocate of that. And this particular poster, which makes the point, what I like about it is it's put up in the Sacramento airport because all the legislators go home for the weekend and they need to see it. And it makes the point, if you go back to the spectrum prevention I showed you earlier, that you can't fix this by individual education. You can't fix this with clinical services. You can't fix this by giving people skills to change their behavior. We need to change the environment. And it lays out very specifically 4 things that people could vote for in California. 4 determinants. So that when you say this is unfair and you're a legislator, it's like, well, here's what you can do about it. But it's the health advocacy voice that's going to determine whether to do it. So one of my goals in this today is, as I said, I wanted to get a little bit more complicated, is to share with you some tools we've developed for communities and practitioners around the country to make this stuff very, very explicit and easy to understand. And one of the tools is called taking 2 steps to prevention, which means going from medical care to behavior and exposure and then to the environment. And let me walk you through it, if I could go in the right direction. So that's the trajectory, as you can see. This was a car crash I came across. Pretty severe, horrendous. Like everyone else, my reaction was, oh my God, call 911. I hope that there's good emergency healthcare services because that's obviously critical in this environment. I hope that's going to work. But we understand, as I said, that medical care alone cannot reduce injuries or inequities because it's not the primary determinant of health. It only treats one person at a time. And because, as I think we can see in this picture, it comes late. And at best, the people who were in that crash were not going to have their health fully restored. At best, they were going to survive. But in that was pretty horrendous. So at first we think medical services, but what if we take a step back and look at, in this case, behaviors, and I show you this picture. Notice how the solution shifts in our mind when we see a picture like this, how our way of thinking and our paradigm shifts, and it's pretty obvious we need to do something more than just invest in emergency rooms and 911. And that makes sense because all of these key issues are related to all the leading causes of death, and we have to deal with those behaviors. But what if we take another step and say, what about the environment? And let me show you why the environment is the key opportunity for prevention. Actual photo, Lexington, Kentucky. Actual photo, a block from my office, Oakland, California. Not quite as explicit, not quite as humorous, but very much the same message. What are the choices we're making? How are we setting up our environment? Are we selling alcohol as people drive at the same time we're saying we need more clinical services? And so this notion of what's sold and how it's promoted is one of the concepts I want to put forth as we think about community environments, because it's one of the elements of community health. Let's do a little equity quiz. These were 2 neighborhoods. This was done in the Midwest, and we did this again in Oakland. Which is the high-income neighborhood and which is the lower-income neighborhood? How many people say the higher income is the one on the left? How many people say the lower income is the one on the left? So what's so amazing, you're of course right, what's so amazing about this country is we take these inequities for granted. We just all know. Of course, if you live in a lower income neighborhood, you're going to have more alcohol outlets, you're going to have less food availability, you'll have about the same amount of carry-out places, but their nature and characteristics are going to be we just take that for granted. But there are things that could be done. After the fires after Rodney King in L.A., about 500 stores burnt down. The city council said, let's fast-track their reopening. This is horrible. We've got to protect those businesses. People who'd been picketing those stores for years said, wait a minute, these stores are doing damage to our community. Why are you reopening them? After a lot of community organizing, 200 stores, which were the most damaging, were closed down. They looked at it, and they found in the 4-block area around those stores a 27% reduction. In crime, in violence, probably even more so in people being harassed. So there are things we can do community-wide to start to have an impact on what's sold and how it's promoted, for example. So that's the whole list. And what this is a list. It's a study we did for the Federal Office of Minority Health of what are the community conditions that are directly related to the leading causes of death, illness, injury, and inequity, and to the behaviors related to death, illness, injury, and inequity. But we reframe them and rename them because we do a lot of community work. And to give something a technical name, wasn't going to work. So we have what's sold and how it's promoted, getting around, jobs and local ownership, cultural competence, names that for the most part people really can get. And when people say now, well, how can we focus on the community factor? You can't measure it in health reform. Yes, you can measure it. We have data, measurable, frequently used data that's used in communities all around the United States, so that not only can you measure for diabetes, BMI, or A1C, you can measure, how many what the fruit and vegetable availability is in a community, how many walkable miles there are in the community, and how safe they are. So in particular, I want to talk about the bridge between healthcare and community health, and particularly what goes on in a clinical setting, which is where many people here are going to end up, and how that clinical setting can be engaged, and how thoughtful practitioners can provide leadership so that we reshape our healthcare system. I really want to move from a healthcare system to a health system. Needless to say, everyone almost I say this to says, Larry, you're crazy. I say, you're absolutely right, I'm crazy. It's impossible. When I did the first no smoking law, I got a call from someone. They said, do you realize how many people smoke? And have you seen that's how big a lobby that is? And have you watched the movies? Not only are people smoking in the movies, but when they have sex, they smoke afterwards. It's like the smoking is the highlight, What are you doing? When Bob Sanders did the first car seat law, which was in Tennessee, the radical state of Tennessee, the American Medical Association of Tennessee testified before Dr. Sanders and said to him, if you listen to the advice of this pediatrician, you'll be taking away a parent's God-given right to make decisions for their own children. Now, at that point, caring parents, and there are many caring parents, and all understood about car seats, yet less than 1 out of 4 kids were buckled up. As we quickly saw laws in every state in the United States, it's very rare now to see an infant who's not in a car seat. Policy is often, norms change is critical for changing behavior, and policy is often the tipping factor for norms change. And healthcare speaking up is one of the most critical elements in norms change and policy change, and the practice of businesses, organizational practice. So there are shared goals between community prevention and health, including improving outcomes, advancing equity, and reducing demand and costs. So we wrote this paper called Community-Centered Health Homes about bridging this gap, and this is what I want to share with you quickly. That's John Hatch and Jack Geiger. Jack Geiger actually was a teacher of mine, and I've gotten to know him very well. These are two incredible advocates. They worked on a multi-county communal farm in Mississippi. And when they started, they said to the pharmacy, you know what, you need to expand and pretty much look like a full-service food store. And Jack started writing prescriptions for fruits and vegetables. Now, the prescriptions were paid for by the federal government, by Medicare, and you might not surprise you to know Jack got a call. Excuse me, this isn't what prescriptions are about. They're about medicine. And so his response, of course, was, well, when I looked in the physician's desk reference, the specific therapy for malnutrition was food. And, of course, kids have problems with worms, and the cure for that is shoes. He got in a little trouble when the medical equipment he tried to order was tractors. But it's a different way of looking much more coherently at the links between healthcare and community health. It's a different way of thinking of the same issues. And so as we're moving via Affordable Care Act and health reform generally, meaning the momentum to reform health, not just the Washington legal momentum to reform health, people are talking about patient-centered health homes. You've heard this before, right? And to me, it's amazing sometimes. As a patient myself, it's a relief but a little troubling to say, going to a place like Kaiser, oh my God, one doctor's going to know the prescriptions another doctor is giving me. That's like groundbreaking, But the notion that health care should be patient-centered of course, is a very, very important advance. But if we understand that community is such an important determinant of people's health and well-being, then we also need to have a notion of community-centered health homes. And so that's why we started to think in this way and write in this way. So here's Chinatown near my office in Oakland. Asian Health Services, a community clinic, is in Chinatown. They had a patient who was killed in this crosswalk. Until you see the picture there, I need to get a better picture of what it really used to be like. You had cars turning right and incredible congestion and people blowing the horn, frustrated all the time. And I know when I'm turning right on a red light, I'm quickly looking to my left to make sure there's not a car coming and quickly turning. And meanwhile, there's someone stepping into the crosswalk. So someone was killed there. And they said, as healthcare providers, can we not only be ready for the next person who gets injured, which was happening all the time a block from their office? Is there something we can do to change the environment? So they sat down with law enforcement, with the traffic people, with the planning people, and they came up with this different design, which is first the light's green in this direction, then the light's green in this direction, then the light's red in all directions, and that's when the pedestrians can cross anyway. And the number of crashes, the number of close to crashes has dropped dramatically. There hasn't been another death since then. So that's good community health. But what's really important about it in this example is that was healthcare as advocates and leaders. That's community-centered health homes. Because they said, rather than fixing the person who's coming in now and expecting there's going to be a revolving door, we're going to use our learnings as an opportunity to understand what's bringing people in and how to fix that in the first place so that the pattern starts to shift. And so just as someone comes into a medical office and you ask the question, why are you here? And you reach the conclusion, okay, this person has some kind of illness or injury, and most important, you write the prescription or come up with the treatment plan. The exact same thing can happen around looking at the community environment and community conditions. And I'll show you an example of that. And the outcome of working that way is going to be improved health, reduced cost, and we're starting to collect an evidence base for how do we really make a difference about stuff like that. And when people say, what are those community conditions and how do we link them with the medical conditions, that's where these elements of community health come in. So obviously, if someone comes in with trauma, it's going to be a car crash, or it's going to be a fall, or it's going to be an incident of violence prevention. And if we don't take those two steps back and say what can be done about that, it's a pretty fair assumption that we'll just continue to have these same efforts again and again. And if we do, we can put a stop to it. Not dramatically. So here's St. John's. This is a clinic. And they came up with, after seeing a lot of patients with different medical conditions, they said, wait a minute, we're calling this asthma, we're calling this lead poisoning, we're calling this falls, and we're calling this violence. But actually what we're seeing is housing-related injuries and diseases. And we realized that when we started to look at patients and realized there were some very, very common patterns based on where people lived. So a kid came in, he had trouble hearing. When they examined him, they found there were 2 cockroaches in his ear. Same housing area, the same situation. So they started to ask a housing questionnaire. And they do this systematically, not at the medical examination, but as people come in and register, because they said in our community, housing comes up again and again as a set of conditions. And when they analyzed that, they realized they didn't have to do it all alone. They had to work in partnership. So when they first realized there were about 7 people they were treating from the same housing area, they called the owner of that housing and they said, hey, we've got some real problems. Obviously, there's some real flaws in your housing and you need to fix it. What did the landlord do? He hung up. So they joined forces with these groups. They ended up having to sue him. And then the housing changed. And as a result of the housing change, of course, we don't see the rat bites. We don't see the mold-related asthma. We don't see the cockroaches in the ear because they said we can have an impact on our community and we can do it by partnering with others. And so this partnership leads to advances and outcomes which ultimately are landlord compliance. So just as we're talking about community-centered health homes, really when we say, so how do you do this, we realize we need to change the entire system. Because you go into a clinic and they say, that's great, but there's no payment mechanism for this. We don't have staff to do this work. Once I get this information in my own practice, who do I go to? So there's a lot of issues around training. There's a lot of issues around funding. There's a lot of issues around rethinking the whole system. There's not doing it all at once by starting with something that's very compelling, just like St. John started with housing. So we need to do this really across the state and the nation. And right now in health reform, there are a lot of opportunities for reframing the work we're doing, including prevention and public health work, the National Prevention Strategy, the Center for Medicaid and Medicare Innovation, and community clinic expansion. I'm going to skip this. I want to talk a little bit about the notion of partnership. And I want to share with you a tool which is called Collaboration Multiplier, which really is kind of the core of how we can think about an issue like this in Oakland, Chinatown. And this is the Collaboration Multiplier. And what it basically thinks through, or helps you think through, is how do we get different sectors to work together? What is their added value? And what can we contribute together? That's why it's called Multiplier. Because by working together, we can accomplish a lot more than alone. So it's easy to see in that picture of the crosswalk how we would engage, say, 4 groups like public health, transportation, law enforcement, and optometry. The first time I brought optometry together with other groups in a transportation issue, they actually showed up. And I said, what are you doing here? And the guy said to me, cover your eyes a minute. Now imagine driving. He said, do you think we have a role to play? And they redid, the group that we worked with here, they redid all the signs. You know, when we went from electric lights to LED lights because of changing power, the lighting had a different color. You know, the signs that say school's open or warning school ahead, what color should those be for maximum visibility? All this kind of stuff should be obvious, and I'd been doing injury prevention for years, but it wasn't obvious to me. But then you look at these groups and say, wait a minute, they all can bring something different to the picture, so we put it together, if we go in the right direction. And we ask them, what's your expertise? What are your outcomes? What are your strategies? We put it together in a grid, and we start to monitor. So what does transportation engineering bring to the picture? What do they know? Or what do you think they want to accomplish? I can't hear you. Traffic what? They want to keep traffic moving. And what are they interested in when there's a crash? Getting out of the way. No, they have to go beyond getting out of the way. Yeah. But that's a good answer. That's probably the best answer I've ever heard. So they're looking at design, you know, they're looking at reducing severity of injury. They're looking at regulations, you know, optometry we talked about. You know, they're thinking, how do people see signs and signals? You know, how do they improve that? What kind of color is good? What kind of design features are good? Pretty soon you have a grid like this, and then comes the hard part or the really interesting part, which is saying, okay, what do we make of this? You know, what are their shared outcomes, their strengths, or their activities? I know you can't see it all. So, for example, you know, public health really brings expertise on traffic safety, whereas law enforcement has some ability to implement changes, and they have different data that they collect. You know, optometry, as we said, will understand about individual behaviors related to visualization, and traffic engineers will know the street design. And it's pretty easy to see how you package all those. You have a much smarter solution than any of those groups working alone, which is why we say a good solution is going to solve multiple problems. Because you put these groups together, it's going to solve all their goals and all their problems at the same time. So to put this back in a medical perspective, it's Hippocrates who said prevention is better than cure. And I want to close by talking about this norms change issue, because it's very easy to look at this and say, okay, that's good. Good examples, good stories, but really, you know, the speaker himself said it's impossible. And it really is impossible. And impossible means we all have to work together. We have to build movements to do it. It's not going to come from one of us alone. So I want to show you a series of pictures, most of which I've been involved in it partially in my career, along with lots of colleagues and others, of norms change. So this was the battle when I first was involved in car seats. I remember a mother coming up to me and saying, I'm so glad you're doing this, Larry, but I love to hold my kid. Ironically, I was with the same mother 25 years later, and she said to me, Brittany should be arrested for being a child abuser. This is totally unacceptable. So that shows how our norms, our own individual understanding changes. Good healthcare picture, right? Not just the doctors, but the dentists. This is now. That's the third smoker we've lost this week. A colleague of mine just said, Larry, you cannot show that picture. They're smoking way too close to the window. Shows you how quickly we change the norms, right? And in San Francisco now, we just passed the first law in the country saying pharmacies can't sell tobacco, which to me should be everywhere in the country, as well as pharmacies can't sell junk food. And I was just involved in another law in Oakland, Alameda County, where we now require pharmacies, and mostly it's the pharmaceutical companies, to take back unused drugs. We don't want to pour them down the drain. We don't want to leave them in the medicine cabinet. There's about 4 or 5 different reasons. It came up for me because I gave a talk like this in Idaho. And a woman came up to me after the talk and said, Larry, I really have to talk to you. And there were about 10 people talking to me, and I could see she was so intense. I said, well, wait till I talk to everyone else. And she told me that her daughter had killed herself. And her daughter had killed herself at the daughter's boyfriend's house by taking all the medication in the medicine chest. Now, obviously, that's very complex. And obviously, if something like this is going on, that's not the factor. That's just one factor. But that's one factor that's really, really easy to fix, except the pharmaceutical companies say it's too expensive to fix it. So we just challenge them, and I hope we can do this here. There's absolutely no reason. It's not good for the water. It's not good for antibiotic resistance. So many reasons. And it's not acceptable to say we can't figure out a simple solution to return medicine. I don't know if people have seen this one. Funny and terrifying, right? Oh, and this was the company that said, wait a minute, affirmative action, why are we just advertising to white people? We got to be fair. We got to get everybody diabetes. So we've emphasized water in California. I actually met with Governor Schwarzenegger, and we showed him a study that showed that more than half the students, when they were eating lunch in California schools, didn't have access to fresh drinking water. He said that's unacceptable, and within a year had passed a bill. And this was the first school that changed its environment to make fresh drinking water the priority. We call this joint use a waste, the tragedy of having available space for physical activity. When, I had the principal of the school near my house talk to me about they had a beautiful running track, and he said, I've got to protect my running track. I can't leave it open on the evenings and weekends. I said, oh, that must be a misunderstanding, because I remember when you were trying to get it funded, and I was a voter that I voted to fund it. And I thought it was my running track, not your running track, because I'm one of the citizens here. And if it's mine, do you really expect me to pay for another one for the park department when we have this right here? And that's the kind of change that we're starting to see. This isn't quite the change yet, but I'll show you one of the busiest freeways in Los Angeles. One day. We're getting there. It'll take a movement. And that's why we think that norms change is like a snowball, and it starts out small and it gets bigger and bigger and bigger. And I just figured out that actually this snowball is the big metal ball that's outside on campus, and it's got to roll down the hill and go through all those hoops. And all those hoops that make it more and more powerful norms change are the actions that you all can take. It's really the momentum building that we all can do together. So that we move from this one, this is my favorite one, to this. And I'm proud. We own this building, and we're very proud of it because we feel like it's a statement that prevention has to be solid and stable and part of a community. Albert Einstein said intellectuals solve problems, geniuses prevent them, but it's actually not true. It doesn't take genius to do prevention. It just takes all of us working together. It takes an insistence on prevention, despite the fact that it's impossible. It takes an outrage of saying when people are sick or injured, we must help them. But if there was any way to prevent it in the first place, and we don't, and we haven't done that, and we don't take action after that, we're missing a life-saving opportunity. We need all our voices to build a movement. So that's it. I've covered a lot of stuff. I have a website. I would love if you have cards or give me your email, and I'll give you my card too to get you on our database. Let me just very quickly go through. We have a textbook, Prevention is Primary, that I know is being used. The goal is to get a new generation to not have to figure out everything we had to figure out, but to start out with a head start in prevention. Oh, these 2 videos, please, you must see. And I have cards on We're Not Buying It. We're Not Buying It is a 2-minute video that basically shows how the food industry will lie to sell food by falsely describing what's in it for kids. You know, and the other tells the story of the day after I did the first no smoking law, where a group called the Tobacco Institute. I never heard of them, but they basically tried to bribe me and said, oh, tobacco prevention is fine. Just don't do that policy stuff. That policy stuff's really dirty. Community-centered health homes, Spectrum, coalition building. Communities taking action is a set of practices all over the country. You know, making it real, how do you do it in communities? Rapid response, if you want to know really how to get engaged. I didn't talk much about violence prevention. It's a very, very important part of our work. And we know what to do to reduce the violence in any city in the United States. I think we could cut the violence by 50% right now with the same resources in the city. It's really a question of political will. It's a question of not doing things the way we used to and not saying it's impossible. We can do things differently, and we must. And it's so hard to change that because people take it for granted that there's only one way of doing it. Dialogue violence. So that's it. So I'd love to take a couple of questions. Thank you.
We'll take a few minutes for some questions. Also, there's more food back there, so I apologize that it was kind of late, but please feel free to get up and grab some or take some with you to your next whatever you're going to.
And tell me who you are when I answer a question. Great. It's a very interesting situation. As I say, we know what to do to prevent violence, and we've been working with the largest cities in the United States for the last 8 years. And we've developed a strategy and a roadmap and a plan. And the first thing we learned when we did an assessment at the beginning of the work by interviewing police chiefs and mayors and education and public health was that the cities that were most successful in preventing violence were not the cities with the most police or with the best community policing or with the best violence prevention program. They were the cities with the best collaboration across the board, community and also between different parts of government. And we've been working on that. And we just completed our 8-year evaluation and basically showed that many cities across the United States have really moved much more to a prevention model. And I think you know that violence rates are down all across the United States, not nearly as much as they should be, and not as systematically. We've developed a roadmap, we've developed a strategy. The catch has been that because we've been funded by the Centers for Disease Control and Prevention to do the work, in our contract it says you cannot talk about firearms. I don't know if people know this, it's very explicit. If you're working for the federal government, you cannot talk about firearms, despite guns being the leading killer. You know, it's like talking about car crashes but not mentioning cars. And so it's an absolutely critical set of interventions. I also believe, tragically, that there's going to obviously, and particularly in a place like Colorado and in many places that are like Colorado or across the country, it's going to be very difficult to move a firearms prevention agenda, even though it would unquestionably save lives, and far more with suicide than with homicide. And that there are many other things we can do as well. And I think it's a both-and situation. And clearly, when you look at, you know, the city we're in right now, the firearms, the magazines, the ammunition, We're in a battle right now about political will. We're in a battle about political will on a lot of different issues. So the firearms is a critical piece, and it's also possible beyond the firearms to make a difference, I believe. Yeah. Multiplier, yeah. Yeah, well, it's strategy. As I mentioned at the beginning of the meeting, my favorite meeting is coffee. And a lot of it is kind of individual connection as well as strategy. But we have 3 or 4 other papers, including a paper I wrote probably 25 years ago, and I'm really amazed it's still used so much, called 8 Steps to Effective Coalition Building. Well, that didn't help. We also did one which is really interesting called The Tension of Turf, because turf comes up so much in partnerships, and the theme of the tension of turf is that turf is not a 4-letter word, and that there's actually a lot of ways to manage partnerships. But I find that the goodwill part of it is an important piece of it. I am feeling, in terms of the healthcare prevention piece, astounded by the level of interest we're getting. It's very small, but it's still, for me, very significant on our community-centered health homes work. I mean, I had 2 meetings with philanthropies here in Colorado this morning that only happened because I was coming here to give this talk. And both of them were incredibly hungry for this kind of approach. And I think people are really looking for options and alternatives right now. And it's a very promising time, at the same time that politics are horrible, financing is horrible, paradigms are not shifting. But I just think it's a question of perseverance. I think that just the question you phrased automatically means you're halfway to the answer. And that's a very, very good thing. Hi. I mean, I think that the legalization of marijuana and the refusal to have restrictions on guns are interrelated and come from, obviously, a Colorado way of thinking. And to talk about a Colorado way of thinking is kind of ridiculous because, there's so many people who think completely differently, and, 52% of the electorate, or whatever the numbers are, doesn't mean anything stable. I think there's a big contradiction between marijuana and alcohol, which has now been reduced by legalization of marijuana, and that there are tremendously serious health care and medical problems with alcohol. And there are potentially serious problems with other illicit or formerly illicit drugs, and that there's kind of a healthcare role in that, and there's a role within the kind of the environment. And the overreaction or the splitting of marijuana from alcohol probably didn't make any sense either. So I feel like I'm not being strong enough or clear enough in an answer other than to say I think there's important public health role, and the role is to go with the law and to basically say what is the added value of a public health perspective. And what is it that we can bring in a way that doesn't necessarily put us on one side or the other side of the issue? Because the issue has just been resolved, And when the issue is resolved, politically, that's what the issue is, And there are other methods that we should work through. And I will think about that more. And give me your card, and I'll answer you again by email. Yes. I think that And I just want to say every place is like that. And Colorado might be more so. Most of the recent governors of California have been Republicans, which doesn't sound like what the state would look like in terms of how progressive it is, and the fact that a Republican may never again, win a presidential election, and they don't even bother to campaign. They just come for money to California. But I would say on some of the issues like getting junk foods out of schools, or taking on the tobacco industry or taking on the soda industry, that the reason we've been more effective in part has to do with the attitudes of the public, but in part has to do with ongoing skillful collaborations from strategic people who said we're going to make a difference and we're going to find the niche. I think that how we define some of these issues, the language we use on some of these issues, is extraordinarily important. How we describe things. I mean, there are some issues which have become nanny state issues. There are other issues where there's much more of an opportunity to say we're speaking for the health of the community. I was the keynote speaker for the awards, dinner workplace awards for the state of Oklahoma. And the person giving out the awards was the governor of Oklahoma, who was very proud of the fact that she was listed as the second most conservative governor in the United States. We talked right before the awards were given out, and she said, Larry, knowing about your tobacco history, I have to tell you that we're taking in the state administration building, we're taking the smoking room and we're turning it into an exercise room. And I was quite mystified and could have said something incredibly reactive, and instead said, well, why did you do that? And she said, because many businesses have said to me that because our healthcare status is so low, they're not expanding further in Oklahoma, despite the fact that Oklahoma City was recession-proof and, they have really good economy, pretty good workforce. We're not coming in because of healthcare. We don't think we can bring in the right people. And she said, I realized I had to do something different. So, for example, getting businesses to buy in, getting faith leadership to buy in, really starting to rethink. And one of the ways, for example, to get businesses that we've been exploring a lot is we've been working a lot with United Ways. We've been working a lot with WISE because we see them as important bridge builders to some communities that we don't have as much emphasis on. We're working with a group in Washington, really smart people, called the Bipartisan Policy Center, which is looking at how do you define some of these issues in a more bipartisan way and how do you describe them in a more bipartisan way. I don't want to be magical about it, though, because if people are opposed, they're going to be opposed, and it's going to be harder. I mean, that's a very significant barrier, and it can ruin work that we're doing. But I still think there can be progress. And what I've always learned about policy is local policy is what bubbles up. I was in South Africa recently taking a photograph in a small town where they had a picture on the window saying no smoking. And the waitress came running out and said, why are you taking a picture here? And I explained that I had done the first no smoking laws in restaurants in the country or in the world. And it was really amazing for me to see it in this small town in South Africa. And she basically, thanked me for what I was doing. But that's a lot of the way it happened. It came from one county, 18 cities, good strategies, having Republican healthcare leaders as some of the spokespeople for that kind of strategy because somehow it hit them. Then let me just close very quickly by talking about lead poisoning. Is lead a bad thing? Who does it affect the most? Children. Which children in particular? Low-income children. Why? Lead-based paint in old houses also because if you're not eating as well, you don't have the nourishment, more of the lead stays with you. What have we, the broader we of this country, done to improve the situation on lead compared to a generation ago? Well, what did we do about 20 years ago about lead? Eliminated lead from gasoline and eliminated lead from paint. Sometimes when I talk to a medical audience, they say screening, and they forget about the spectrum prevention. Right? We eliminated lead from gasoline and we eliminated it from paint. Did the gasoline companies support this movement? It's hard to understand why not, right? But I understand it because ever since we took the lead out of paint, they've been in horrible financial shape, all those petroleum industry, right? So who took the lead out of paint? How did it happen? Politicians, right? And was it really the politicians who were the tipping factor? I'm looking for a two-letter word. We did. That's exactly right. And it's a we that's not exactly the same we as here, but it's the same community with the same vision. We did it. By collecting political will, by developing that kind of impact, we can accomplish whatever we need to. I mean, you here are a significant chunk of a critical mass of the new leadership in health in this state. It's just a question of our own insistence that as long as it's impossible, that means it's doable. So I hope this was helpful. It was a lot of fun for me. Thank you all.